Hello and welcome to today's Center for Healthcare Strategies webinar made possible by the Robert Wood Johnson Foundation and Kaiser Permanente Community Benefit on integrating community pharmacists into complex care management programs. This webinar is the last of a three-part series on exploring workforce innovations in complex care. Before we get started, I'd like to quickly go over a few logistics. To eliminate background noise, phone lines are being muted during today's event. There will be a moderated question and answer session following today's presentations. You may submit a question online anytime by clicking the Q&A icon located in the drop-down menu of the toolbar at the top of your screen. Instructions are shown on the screen at this time. Today's event will be recorded and shared publicly on CHCS.org. At the end of the webinar, we ask that you please complete a brief online evaluation that will pop up on your screen. Your feedback is very important to us, and we hope you'll take a moment to do this. I will now turn the webinar over to Rachel Davis, Associate Director at the Center for Healthcare Strategies.
Great. Thank you, Travis, and hello, everyone. I'm Rachel Davis, Associate Director for Program Innovation at the Center for Healthcare Strategies. We're really excited to have you all with us today for the third and final installment in our webinar series on workforce innovations for complex populations, and wanted to thank our funders, the Robert Wood Johnson Foundation and Kaiser Permanente Community Benefit, for making this series possible. Today's webinar features Trista Pfeifenberger and Joe Moose of Community Care of North Carolina, and they'll be speaking to their organization's pioneering work to integrate pharmacists and expand the role of pharmacists within care teams serving high-need, high-cost populations. As many of you likely know, Community Care of North Carolina has been a national leader in caring for complex, low-income populations for several decades, and their use of data-driven strategies and scalable approaches is really one of the aspects of their work that makes them stand out in this landscape. We're excited about today's presentations because, as all of you on the line know, we spend a lot of time in this field thinking about how to provide better care to patients in a way that improves their health and reduces unnecessary costs and utilization. Today's presenters, Trista and Joe, are going to highlight what we at CHCS think is somewhat of an underexplored part of this equation, pharmacy and pharmacists. As you'll hear from Trista and Joe, there's really a tremendous opportunity that CCNC, we think, has helped uncover to achieve the triple aim with complex populations by directing resources towards this area of pharmacy. CCNC's work in cultivating a network of community pharmacies to explore and contribute to this effort is a hugely exciting innovation in the field, and we're so pleased to have them on the line to share this with you. In terms of an agenda, it's fairly straightforward for today's webinar. I'm going to make a few more comments for the welcome and introduction sections, and then we'll go right into Joe and Trista's portion of the conversation. We'll also have plenty of time today for a Q&A portion of the discussion, so we really encourage you all to submit your questions throughout the conversation and including once we get to the Q&A portion. So in addition to myself, I'm joined by my colleague, Caitlin Thomas-Hinkle, who's a Senior Program Officer at CHCS, and I'm also joined by Misha Knight, who's a Program Associate with Robert Wood Johnson Foundation. I'm going to turn it over to Misha in just a second, but before I do so, just very quickly wanted to say a few words about CHCS and some of our initiatives. So CHCS is a nonprofit policy resource center dedicated to improving the health of low-income Americans. We work with a really broad range of stakeholders, including delivery systems, payers, and states on issues ranging from everything to do with payment and delivery system reform to integrating services for people with complex needs and enhancing access and coverage to services. I also wanted to highlight two of our CHCS initiatives focusing on complex populations, the Complex Care Innovation Lab and Transforming Complex Care. As you can see here on this statewide. The Innovation Lab is funded by Kaiser Permanente Community Benefit and gathers leading organizations from across the country to advance emerging opportunities to improve outcomes for low-income individuals with complex medical and social needs. We were thrilled to have Community Care of North Carolina recently join this initiative and are really excited to feature them today as a member of this group. Transforming Complex Care is a Robert Wood Johnson Foundation funded initiative that is supporting 2-year pilots among 6 sites in Montana, Vermont, Northern California, Wisconsin, South Carolina, and Virginia. This work is really aimed at advancing the field's understanding of how to refine and spread effective complex care models. And the past 2 webinars in this series featured a number of TCC sites. If you haven't caught the first 2 webinars in this series, we do encourage you to check those out. They can be found on our website, chcs.org. And so, Misha, I'd like to turn it over to you here to just very briefly speak about Robert Wood Johnson's commitment to this work and where you all see it fitting into your culture of health vision.
Great. Thank you, Rachel. And great big thanks to Caitlin and CHCS for organizing today's webinar. We're so glad to be partners in this effort to transform care for patients with complex needs. Thank you also to Kaiser Permanente for your support and to our speakers and everyone who has made the time to join this discussion today. I look forward to learning alongside with you all. As Rachel mentioned, I'm Misha Knight. I'm a program associate at the Robert Wood Johnson Foundation, and I'm thrilled to be joining you from not too windy Chicago today. If you hear any distracting noises, I'm pretty close to a window, so I apologize in advance. I think we are all looking forward to today's presentation, and so I won't spend a lot of time. I'll just share really brief comments to help you understand and fit in better your how you're thinking about this work and how the foundation is thinking about it also, and how it all fits together in the broader context of our efforts to build a culture of health and the building blocks we call our action framework that served as a guide toward our common goal of better health for all. Many of you already know that the Foundation has organized its work in 4 broad thematic areas focused on healthy communities, healthy children, health leadership, and health and healthcare systems. The latter area, health and healthcare systems, is the area where I spend most of my time and where this work resides. Transforming health and healthcare systems is the official title, and the work we do here aims to strengthen individual systems such as healthcare, public health, and social services, and make it possible for them to work smoothly together and focus on what matters for individuals and families and communities. In addition to the broad areas of focus that I mentioned, the Foundation has laid out a framework to help drive toward integrated, equitable, affordable health and healthcare that meet the needs of all these individuals and communities, but especially patients with complex high needs. Rachel, I'm going to ask you to switch the slide if you haven't done so already. Thank you. What you are now seeing here are 4 building blocks. First, we know that in a culture of health, the concept of health is a value that's shared by all members of the community. In a culture of health, health and healthcare systems are strong and integrated. There's an overarching focus on building health equity into all our communities. And finally, there's shared leadership and commitment across sectors to ensuring that this happens. I think this helps to paint a picture of how this initiative helps us to support complex high-needs patients and the needs that they bring to our health and healthcare systems. But I'll go one step further to highlight 2 most pertinent areas that this work helps to advance. And those are action areas 2 and 4. so much of the work we see happening and are thrilled to support are dependent on cross-sector collaboration and integration of areas that for long times have been very siloed. We recognize that we can't do this work by focusing solely on healthcare or even just on social services. It requires the harmonious marriage of different sectors in partnership with communities to serve the individuals, especially those who are at greatest need. We know that there's certainly no shortage of things to keep you all busy, and that you are doing this work with limited resources and are seeing really great outcomes. So we are particularly grateful for your contribution, for your continued commitment and leadership, and we are especially grateful that you've taken the time today to join us to hear more about our efforts and to continue your work in the vein of building a culture of health. Thank you all so, so much. Rachel, I'm going to turn over to you now.
Great. Huge thanks, Misha. That was great. And so it's my pleasure now to turn it over to Joe and Trista to present their presentation here, Cultivating an Enhanced Community Pharmacy Network to Serve Complex Beneficiaries. Just to do quick introductions to the speakers. Actually, you're first going to hear from Trista, who is the Director of Network Pharmacy at Community Care of North Carolina. And then we'll hear from Joe, who is the Director of Strategy and Luminary Development at Community Care of North Carolina, but is also the co-owner of Moose Pharmacy. So with that, Trista, I will go ahead and turn it over to you. Thanks so much.
Wonderful. Thank you for those warm introductions. We're really glad to be with you today. Before we get started, I would like to just share a quick disclaimer statement. A lot of the work that Joe and I are going to be describing today is funded through a 3-year award from the Centers for Medicare and Medicaid Innovation, and we need to let you know that the information presented today is our views and essentially not their views. For those of you who are not familiar with Community Care of North Carolina, which I'll probably call CCNC for the rest of the presentation, I'd like to give you a little bit of background about who we are. I've worked with CCNC for the past 8 years. We really have a group of 14 regional networks that each has its own medical leadership. There are primary care physicians, pharmacists, care managers who are both nurses and social workers, psychiatrists, obstetric champions, et cetera. Those 14 regional networks are designed so that we can provide care locally to 1.6 million Medicaid beneficiaries who are enrolled with CCNC. That consists of around 300,000 age and blind disabled population and somewhere between 150,000 and 200,000 dually eligible patients. Our care management program is accredited under NCQA, and we do a lot of focus on population health, really convening community partners, focusing on high-risk populations within Medicaid, which certainly includes high-risk obstetrics and also behavioral health. The medical neighborhood that we have built at CCNC consists of some of the folks I just described. It also includes groups who are focused on quality improvement within practices and really supporting practices in the medical home model. They certainly include our community partners, such as hospitals, home health groups, et cetera, and a lot of community resource providers. And as it relates to certain specialty disease states, hepatitis C being a good example that is kind of a hot topic right now, also relationships and partnerships with specialty providers. And you can see I have pharmacy highlighted here as a relatively newer member of the CCNC medical neighborhood. The CCNC model, as I just described it, has been in place for the last 7 years. We've actually been in North Carolina with a statewide footprint for about the last 20, but some of the more recent programs, such as behavioral health, high-risk obstetrics, and even some of the pharmacy components I'm going to talk about, have been in existence for approximately the past 7 years. CCNC has had multiple external evaluations. I think we're now at 5 external evaluations that have been done to evaluate the effectiveness of our model, where the care team I just described is integrated with over 1,800 patient-centered medical homes across the state. With that medical home model, we've been able to show a 3-to-1 savings for the state, so $1 spent on CCNC provides a $3 savings, and we've accomplished that mostly through the data you see on the slide here, which is a 45% reduction in inpatient admissions, a 35% reduction in preventable admissions, a similar decrease in preventable readmissions, and also a decrease in emergency department visits. All of that while the patient's utilization of their primary care provider and of medications increases. And so, again, this same equation for our success has essentially been found by 5 different external evaluators over time. It is worth noting that this model, when it was tested, was prior to the Community Pharmacy Enhanced Services Network we're going to describe today, but these evaluations were done during the point in time that there was a pharmacy program in existence at CCNC, and I'll describe a little bit in a minute or two what that evolution looks like. Going beyond utilization, we've also focused, as any primary care case management group would, we have focused on medical outcomes as well, and also patient satisfaction. So to go beyond utilization, we do have multiple HEDIS measures that the state uses to evaluate CCNC's performance. We do also report data on the satisfaction of patients with our care management program. And in terms of our results on these, we have found that many of the measures, such as the ones for diabetes and hypertension, CCNC has performed very well over time, often even beating not only the HEDIS mean, but often the 90th percentile as well for Medicaid populations. You may wonder, why does a program that has all of these robust resources need a pharmacy program? And the data I'm about to share with you here is actually representative of Medicare patients, but I'll show you in a minute we have very similar data for our North Carolina Medicaid beneficiaries. And that is, if you look at the patients with multiple chronic conditions, usually 3 or more chronic conditions, in a Medicare population, those patients see 13 different providers, takes 50 unique medications each year, and are over 100 times more likely to have a hospitalization. That is a very compelling reason to really provide medication management to these populations. Clearly, there's also some care coordination that's potentially needed there, and what we'll describe to you today is how community pharmacy can fit into that model. When we look at CCNC's pharmacy program history, so our care management program and primary care infrastructure is 20 years old. Our pharmacy program is 10 years old. And we did have a community pharmacy partner, who is Joe Moose on the line with me today, from the very beginning. But by and large, for the first about 7 years of our pharmacy program's existence, it was pharmacists based in hospitals, pharmacists based in the primary care practice, some of them based more in an office location where they could do more of a population health model, maybe do some home visits, things like that. And over time, what we really discovered was that if we wanted to have a model where all of the high-risk population, as it related to medications, had face-to-face access to a pharmacist, we knew we needed to staff our model differently or resource our model differently. Even when we were fully built out prior to introducing community pharmacy, we had about 40 pharmacist FTEs. It was 70 individual people. Across those 40 FTEs, they were spread around the state in the care settings I described. But as you might imagine, those resources don't go very far in 100 counties, 1,800 medical homes, and across 1.6 million people. And so community pharmacy, it became clear to us, was our way of really being able to access all the high-risk patients who need enhanced medication management and getting geographic reach. Well, you may wonder, in addition to the geographic reach, why else might community pharmacy be an important partner? We started to look at the data and really found, as you look at this graph, that if you go across to the right, you're looking at a more complex patient. And essentially what we found is that the most complex patients, the ones that are most in need of medication management, that are also high risk for care management and other needs, Those patients see their primary care provider 2 to 3 times a year, but are in their community pharmacy 20 to 35 times a year. So when we think about a touch point from a population health perspective, it is tremendously valuable. Not to mention the fact that if any of us see another healthcare provider 20 to 35 times a year, we're likely to have a pretty good relationship with that person. So not only is it the reach of community pharmacy, but also the existing strong relationships that many patients have there and the opportunity to intervene on a very regular basis with this complex population. So we developed in 2014 the Community Pharmacy Enhanced Services Network, and our goal was, like I described before, essentially to build out our medical neighborhood and add to the existing pharmacy program with a community pharmacy infrastructure. We felt that there were very important components of the community pharmacy intervention that would be tied to the dispensing of the medication product. And so along those lines, we created what we refer to as a list of enhanced pharmacy services. And the services you see on the screen are not really ones that pharmacies are typically reimbursed for. Often pharmacies have provided these services historically without a charge or perhaps with a very modest fee to the patient. But really what we thought was most valuable about these services is that they go a very long way toward addressing social determinants of health and health literacy challenges that can stand in the way of patients getting the best outcomes from their medications. So some examples exist here on this slide. For instance, our care managers within CCNC work with many patients who lack adequate transportation to and from their appointments. And that can easily be arranged when they go to a provider a couple times a year. But obviously they can't get transportation easily to the pharmacy 20 to 35 times a year. Many of the pharmacies that we work with in the Enhanced Services Network offer home delivery. And so that is tremendously beneficial. And Joe will likely talk about what the delivery drivers do in these roles. It is very, very different than just dropping the medications off at the door and heading back to the car. Also, when you think about health literacy challenges, the patients we work with at CCNC, at least the most complex, 5 to 10%, many of them have severe and persistent mental illness. Many of them have extremely complex medication regimens. It's not uncommon for the pharmacists working with us to see regimens that are 10, 15, 20 medications that the patient takes on a regular basis. And as you might imagine, it takes a lot of effort to keep all of that organized. Maybe 4 of those are at 9 a.m. There's 2 that need to be taken at noon. These 2 need to be taken 2 hours apart from each other. This one's with food. This one's not with food. When you start to think about the complexities of a regimen that complex, obviously some supports might be needed for patients. These pharmacies offer things like synchronizing all the medications to a single date each month and packaging them in blister cards so that a patient just goes to a single card for all their 9 a.m. meds, a different blister or bubble pack for their lunchtime meds, for their 5 p.m. meds, et cetera. It makes it much more easy for patients to be adherent to their regimen. Many of these pharmacies also monitor vital signs and report those back to the provider. Some of them are willing to do home visits, sometimes in conjunction with a care manager, which can be incredibly valuable. Hopefully it's obvious as I describe these how these services could really help address social determinants and health literacy challenges. So we started this network in 2014, and as of the beginning of 2017, we are over 275 community pharmacies participating in this network model. Importantly, these community pharmacies are fully integrated with the rest of the CCNC model, so they work hand in hand with care managers, with providers, also with pharmacists that are part of hospitals or part of primary care providers and already working with CCNC. That integration is essential to the model. The other really important piece about the model is that these pharmacies are willing to be held accountable for medical outcomes. So pharmacies in this network regularly receive data on how they're doing with total cost of care, hospitalizations, and rates of ED use. Those are the exact same metrics that our primary care practices are measured upon, and we feel like that is critical if you're going to be part of the team as a pharmacy, that we really need to be held accountable to the same metrics as the rest of the care team. In terms of what the care team integration looks like, we get a lot of questions about that. It's obviously very locally based for a reason. That's one of the reasons why CCNC has 14 networks as well. We really believe that all care is local, and care managers really being boots on the ground in those areas is important. That's some of the same reason we feel like having this community pharmacy component in the community is very important. To give you some context on how this might look different if I was a primary care provider or if I'm a care manager, I'm going to share some examples with you. Think about a primary care provider who has a 15-minute visit with a patient. They're trying to figure out what medications need to be adjusted, and usually the most they have at hand is what they have prescribed in the system, whatever the medication list was in their EHR at the last visit, and maybe a patient filled out the form as they are waiting for the physician to see them about what their current med list is today. And in 15 minutes, a provider is trying to evaluate all of a patient's medical problems and whether any of those medications need adjustment or monitoring. A tall order, to say the least. Well, do these providers have confidence that the patient gives a complete and up-to-date medication list? In that traditional model I just described, does the provider have information about how adherent the patient is to their medication or any issues they're having with side effects before they change therapy or increase the dose, determine that a certain medication is not effective for a patient? In our experience, the answers to those questions are commonly not, and that's one thing we hope to repair with the CPESN model. The idea is that these pharmacies and providers are collaborating with one another very regularly. This goes well beyond refill requests and well beyond prior authorizations. This is the pharmacy communicating with the provider that, here's the patient's adherence to their prescriptions over the last 3 months. This is them saying, the patient was in the pharmacy the other day, we took their blood pressure, and here's what it was. This is saying, we got a report from the patient that they're having this side effect after recently starting a new medication. Can we consider something different? It's those type of dynamics that Joe will describe further in just a moment. I also want to talk a little bit about what the relationship looks like with care managers. Again, our care managers, it is a boots-on-the-ground model. The care managers commonly do home visits on the most complex patients. From time to time, the pharmacies will join the care managers on those home visits or do a home visit of their own. And by and large, sometimes we get questions like, well, the care manager is already doing medication education. How does the pharmacy add on to that? And the care manager is also doing medication reconciliation. Well, the pharmacy adds on to that from several aspects. First of all, they're able to really clinically assess the patient's medication regimen and how it's being monitored and make recommendations to the provider accordingly. They're also able to work with the care manager on many of these social determinant type things that a care manager could find in a home. Example is, care manager goes into the home and realizes that the medications are very disorganized. They need some kind of either pill box fills or something more than just the traditional prescription bottles in order to be successful with their meds. If that's the case, the care managers can educate the patient about CPESN pharmacies and potentially make a recommendation for them to consider several of those local pharmacies that offer adherence packaging. Another example is identifying patients that have, maybe they're non-English speakers, and so they need a pharmacy that can communicate with them well. Maybe they have a high-risk opioid regimen, they need access to naloxone, or they find they're not taking their inhalers properly. I can tell you from my own experience, this is incredibly common. Care managers find that the patients are not using an insulin or inhalers correctly and really need more than just the standard pharmacy education that would be provided for those, and they can refer to these pharmacies for those types of services. The care managers and the pharmacies really do work together in an integrated fashion and essentially partner together to form a care plan and work with one another for as long as the care management period is ongoing, and then the care manager will often hand off to the pharmacy at the completion or when they're wrapping up their care management encounter. One of the pieces we are commonly asked about is, how is this model financially viable for community pharmacies? And I mentioned earlier that we have a CMMI grant, and that is really how we have been able to make the model sustainable for our North Carolina pharmacies. We've been able to test value-based payment models and really figure out what works in terms of, an appropriate rate of payment that is both an incentive but also, reasonable for the population in the care. We are able to test what types of performance measures can be woven into that value-based model, and the pharmacy can be held accountable for those. I think I described those earlier. But beyond the grant, we've had conversations with a number of payers who are interested in this topic, and the question that always comes up is, well, how would we try to compensate for the pharmacies for these types of activities, knowing that the pharmacies are normally reimbursed for their drug dispensing through a pharmacy benefits manager, but the improvements in medical outcomes that come from the pharmacy's care are usually paid on the health plan side or on the medical side of the benefit. So along those lines, we've shown here on this slide, there's several different ways. One option would be for the pharmacy to have, really for the first time ever, a direct connection to the health plan that goes beyond the pharmacy benefits manager, where they could be compensated for essentially the medical care that they're providing, or the clinical aspects, the non-product aspects of their care. The other way would be to have some sort of value-based model where savings achieved on the medical side were essentially provided to the pharmacy benefit manager to pass along to the pharmacy, since the payment relationship between the pharmacy and the pharmacy benefit manager already exists for most health plans. And before I close out here and pass along to Joe, I see a question about the CMMI grant, and I'm sorry, that was the one I was describing at the beginning. So this is the Centers for Medicare and Medicaid Innovation Award. It's a Healthcare Innovations Round 2 award that CCNC was given to study very specifically community pharmacies' integration into the medical home infrastructure. So with that, I'm going to pass along to Joe. Thank you all.
Thank you very much, Trista. I'm Joe Moose. I'm a community pharmacy owner, and I've worked with CCNC since 2007, and my role since 2007 is how do we weave community pharmacy into this medical home model. I think historically, up until that time, at least in North Carolina, community pharmacy operated pretty much in a silo. So how do we bring it into the community pharmacy model? I'm not able to advance slides, so if you could advance the slides. Apparently it's not working on my end. Thank you. So what we're really talking about is a little bit different than what's made news lately for pharmacy and for payers. And star ratings are about some type of quality metrics that a payer may have set up for us. And so what a star rating would look like would be something like a blood pressure medication, say an ACE inhibitor. Was that prescribed for that patient? Maybe the doctor gets a good star rating if he prescribes it, and the pharmacy gets a good rating if they fill it and the patient picks it up. But what we're really talking about is a bigger deal than that. Is that medication getting them an outcome? Is it lowering their blood pressure? And really what we're talking about is not just is it meeting some type of surrogate marker, but is it preventing total cost of care, reducing total cost of care by preventing hospitalization? So we're trying to move from a rating type model to a total cost of care type model, reducing hospitalization, reducing ED visits, or kind of the way we refer to it is we're moving from prescriptions to patients. Next slide, please. So what we did to do this is we really refocused our whole pharmacy. So if our old model and our legacy model was to fill prescriptions fast, accurately, and cheap and do everything to hit those three aims at the most efficient way we could do it, we changed our model and we really focused on the end game is reducing that total cost of care and getting better quality of care for the patient, and not necessarily getting the drugs. And we learned real quickly that we could not do this alone. We started this very robust adherence program where I went out and I hired the best clinical pharmacists in the nation, in my opinion. We invested in technology that would allow us to package the medications in a little strip packaging where each dose of the day was in its own individual package, so all the breakfast medicines were in one little pouch, all the midday medicines were in a pouch. We had a system where we'd call the patients and check in on them frequently during the month, and we went around to all the doctors in our community and told them, send us your most complex patients, and we'll really take care of them, and we'll reduce their total cost of care. We'll keep them out of the hospital. So they finally sent us some patients, and we put them through our program, and we found out real quickly that we couldn't do that. And the reason we couldn't do it is we thought it was a pharmacy problem and a pharmacy-centric problem when it was truly a medical neighborhood problem. When we started talking to the care managers about, hey, what are you seeing out there? And here's the care plan, and started talking to the primary care physicians, nurses, and the primary care physicians, and talking to their psychiatrists, and started communicating across different spectrums and sharing what it is we did to help with the other care team members, as well as sharing what we found with the care team members, and then sharing what we plan to do next, and all the while keeping the patient's aspirations about their condition in check. One of the things that we don't really have a good grasp on in medicine is signals of failure. We may see that the physician has prescribed everything just like the guidelines say it. He prescribed these over to the pharmacy. The pharmacy may have filled it, and the patient never took it, or the patient never came and picked it up. And nobody's ever communicated that failure back upstream to the physicians or to a care manager or to someone who, at the pharmacy who could reach out and say, hey, why didn't you get this medication? What were the barriers in place to keep you from getting the medication? Next slide, please. So I kind of want to spend the next little bit of my time just kind of walking you through in a day in the life of what's going on behind the pharmacy counter. When you walk into your pharmacy, you probably see a lot of people and a lot of pill bottles behind the counter, but what really is going on behind that counter, at least at one of these community pharmacy enhanced service pharmacy. So a CPESN pharmacy, what you'll see behind the counter is dramatically different than what you would see in a pharmacy who is still in that model of filling a prescription fast, accurately, and cheap. So our goal in North Carolina with the grant that Trista spoke about was not to change what every pharmacy in the state did. And it was not necessarily to completely change what any of the pharmacies did. We felt that there was definitely a differentiation between what a small subset of pharmacies did in the state, and we wanted to leverage what they're doing. So as Trista pointed out, they're seeing their primary care doctor 3.5 times a year, but they're seeing their community pharmacist 35 times a year. How can we leverage those 35 touch points to drive home a specific outcome? So again, we're not talking this is happening in every pharmacy in North Carolina or every pharmacy across a CPESN network across the state. So we'll walk through, the actors in this play we have adherence techs, inputting techs, clinical pharmacists, dispensing pharmacists, cashiers, and delivery drivers are the primary actors in this. Next slide, please. So an adherence tech. An adherence technician is going to come in and start their day. They're going to identify patients and get them queued up to have who's going to be called that day. They're going to call patients who have had drug therapy problems or who have had problems identified with adherence. So they're going to start out their day with a list of patients that have been identified as being at-risk patients. And this comes from analytics that CCNC provides to the pharmacy about the riskiest of the patient. So they're actually scored by a number. So we know like a patient who has a risk score of 99 versus a patient who has a risk score of 50, we're going to put our effort, burn our calories on the patient who has the risk score of 99. We saw this over a group of patients, and in some of our earlier analysis, we had touched close to 10,000 patients on it, and their impactable cost of these patients for that group was $1,100 was the average impactable cost. So these were, again, high expense patients who were spending somewhere upwards of $25,000. And if we took those 10,000 touched and extrapolated that over a year's savings over our entire population, we're talking somewhere around $66 million of dollars spent or dollars saved with this impactable population. So again, it's very important that we're not doing this for every patient. We're doing it for 10, maybe 5% of the patients, but it's the 10 or 5% of the patients that are at the highest risk and have the highest impactable cost out there. So again, this adherence technician is looking at drug therapy problems that have been identified earlier. They're looking at a list of patients who are not adherent. They're processing these patients' medications, reaching out to the patients if they need prior authorizations, if the insurance is rejecting or whatever. They're coordinating those type efforts. They're calling these patients every day, all day long. They're connecting with them. We're really big on building stickiness. So when they hear a dog barking in the background, they say, "Hey, do you have a dog? What's your dog's name?" So the next phone call to this patient later on that month or the next month, they're like, "Well, hey, how's Coco doing?" You're really trying to build a relationship and build stickiness with these patients. The same technician calls that patient every month. They have scripts that they're going down based off certain conditions where they're asking trigger questions and they know handoff points. So they may be asking a patient with CHF, "Hey, do you have a way to weigh yourself? Do you have scales in your home?" You do? Good. Have you gained more than 2 pounds in one day or more than 5 pounds in 1 week? Oh, you have. You gained 12 pounds last week. Okay, well, that would be a flag to that technician that she needs to hand that phone call off to a pharmacist to have a conversation, possibly get the patient in, look at what their regimen is. So our inputting technicians and our counting technicians, they're running these queues that have been set up that have identified what are these drug therapy problems, what are these patients who are having adherence problems. This drug therapy problem follow-up queue is in their pharmacy management system. So they're calling patients, calling doctors, insurances to get the medication side of it all queued up so the patient can get the medications that they're put on. So these two things are happening, simultaneously but in concert with each other. They're also assisting the pharmacists with inputting data that the pharmacists, the notes that they have found during their comprehensive initial assessments when they're sitting down doing this medication therapy management type activities, when they sit down and have one-on-ones that maybe last anywhere from 30 minutes to an hour and a half with the patient. So they're doing the data inputting. Next slide, please. So again, here are two more roles as we're peeling back this onion of what's going on. Again, not the fast, accurately, and cheap model, but the actual what is it we can do to keep patients out of the hospital model. So our clinical pharmacist is coming in and they're looking at those queued up things from that attribution, that list of high-risk patients. They're identifying who is eligible for a comprehensive initial pharmacy assessment. They're identifying patients who need a follow-up from yesterday or last month or last week's comprehensive initial assessment. They're contacting patients telephonically. They're having patients who are coming in for a face-to-face visit, and they're working with these patients all day long. They're figuring out how do they resolve this drug therapy problem. We found a drug therapy problem in our 45-minute face-to-face visit last week with them, and we're still trying to resolve that problem that we found. It may be something like patient was on 2 drugs that are basically the same thing, or that the patient doesn't have a drug that they feel like should be on board, or it may be that the patient doesn't have access to the medication simply because they don't have transportation. So how can we can coordinate delivery to them, or maybe they're homeless and they don't have a home to deliver to, so we're trying to coordinate a common drop-off. Then the dispensing pharmacy is the pharmacist you would commonly see behind the counter in most any pharmacy in America. You would walk in, and they're working on following up with the drug therapy problems that were found in these longer sit-down face-to-face CPA type questions. That they're also, as they're filling the prescription, they're identifying drug therapy problems then. So if a patient walks in to get amoxicillin filled for their cold, we're getting a trigger that, oh, they're also, although you're filling amoxicillin, we see that this patient is late on filling their simvastatin for their cholesterol. So they're handling those type signals of failure that are popping up. Next slide, please. So our cashiers are doing more than ringing up the transaction. The cashiers are tagging these bags and to alert the patient that this patient has been identified as needing a face-to-face meeting with a pharmacist or a technician, and when that patient comes in, they're scheduling these visits. They're acting as schedulers and trying to get these complex patients on the fly when they just happen to walk in. They're also giving us, again, a signal of failure. They're notifying us if a patient is declining a vaccination or if a patient is declining to have a CPA sit down with our pharmacists. And then probably one of the roles that has changed the most dramatically over time is our delivery driver. Our delivery driver used to be someone with a good, clean driving record, and they would take a bag of medicine out to a home and they would get a signature for it. So, I mean, I think in our legacy pharmacy system, it was either done by mailing prescriptions or still today done by mailing prescriptions or going to somebody's door and handing somebody, whoever answers the door, a bag and getting a signature that you got the bag. So what we really did is we felt like our delivery drivers were in the home, and we felt like the information that we get from someone where they live, work, and play is so valuable that we wanted to capitalize on that. So our pharmacists also go out, our clinical pharmacists will also go out and do home visits for patients who can't come in to the pharmacy. And the information we glean in a home visit, we really thought that got us leaps and bounds towards reducing total cost of care and helping the quality care of that patient, that we said, why can't we train our delivery drivers like a community health worker role, where they're our eyes and ears and they're really a conduit. So they act as a bi-directional conduit of information. They're taking messaging that the pharmacists and the clinical pharmacists have found to the patient if we're not able to get in touch with the patient. And they're asking, they have scripts that they work off also, so they'll ask the patient's questions, and if they get trigger answers, then they won't get the medication. They'll either FaceTime back to the pharmacy or Skype back to the pharmacy or call into the pharmacy to have a conversation before they actually leave medication with them. So they've turned into just a really robust partner in our delivery of care. And you know, another thing that they really is valuable is they're getting contact information. With this patient population, the contact, the addresses change frequently. They're a pretty mobile group of people in the fact that they may not move long distances, but they may move several times in a year or maybe even several times in a month. So having contact information in terms of telephone of them, their parents, their cousin, their neighbor, their different people, so you can try to track these patients down. We learned early on that these disengaged patients are super expensive to the healthcare system. So it's not the patient with 3 chronic diseases that takes 14 medicines a month that's the most expensive patient. It's the patient with 3 chronic conditions that takes 0 medicines a month that really is the most expensive patient, because they end up in our emergency departments and end up in our hospitals. Next slide, please. So this is sort of a typical script like one of our delivery drivers may have. Are you having any problems with your medication? If the patient replies yes, they would stop and call the pharmacy. Have any of your medications been stopped by your doctor? These same questions are getting asked by our technicians when they can get in touch with them on the phone. But if we notify to the delivery driver that we didn't get in touch with them, or we notify to the delivery driver that everything's clear, and they go through these questions and get a different answer from the time that we actually called them and prepared their medicine to here, then these are all stop measures that would force the delivery driver to take some action in terms of reconnecting that patient back with the pharmacy. Next slide, please. So kind of what I want to do with this next series of slides is just show you a little bit of how we learned and how we didn't start out where we are today. We started out by doing things and failing at them and kind of reiterating and reiterating. You know, you don't drown by falling in the pool. You drown by falling in the pool and staying there. So our idea was, hey, we did this wrong. It's not working. What can we tweak to do it? So what you'll see here is are the steps involved in a comprehensive initial pharmacy assessment. They take the attribution list. They request a list of drugs from the primary care physician and a list of drugs from all the specialists. We may do a home visit at that point in time. Out of the 1,000+ home visits we've done, we get a drug list from their physician and their specialist. We have not had one patient yet that is matched up with the drug list that the physician has supplied. You would think at some time out of 1,000 you'd get lucky and somebody was doing it right, but we always find discrepancies there. So we would go into Pharmacy PH's Pharmacy Home, which is a portal that gives us information of paid claims data. We would go look in there to ensure that the patient hasn't been reviewed by somebody else. We would call the patient and try to get a face-to-face set up. We would complete this comprehensive initial pharmacy assessment with the patient and the caregivers, try to get them involved in that too. We would complete a matrix of listing out all the drugs that they really are on, and any other drugs that may be over the counter, those type things, and we would list out our drug therapy problems that we would find. We would complete the CMR notes and summary and publish all that back to the pharmacy home system so a care manager could see what we found or a physician's office could see what we found. And then we work with the rest of the healthcare community, like Trista pointed out in one of her first slides there, that whole medical neighborhood, to resolve any of these drug therapy problems. So these first few things that were, all of these were done by pharmacists. Then we started moving on, and those you'll see as you click through these slides that are in blue could be done by, a lot of this could be done by a technician and support staff. So it made us much more efficient over time. So we failed at it. We were only able to do about 6 of these a day, and there was no way we could get through all the patients at 6 a day. So we started putting technicians in certain roles, and we started hiring scribes to do some of the documentation. And we got that 6 up to 12, and we went back and said, okay, how can we get it, up to 14 and up to 16? So what we really did is we asked ourselves, are we doing the best we can do, or we changed it from that mentality to are we doing the best we can do to are we doing the best that can be done? And when we started looking at things through that lens, we started getting really efficient at delivering this care and letting everybody in the pharmacy kind of up their role. Next slide, please. So what were our real learnings, or what are our takeaway with this is to make this work, we had to have frequent discussions with our team. We had to have everybody you saw, those roles we just went through, in a meeting weekly when we talked about providing this value-based care. And when we learned that when we did this, we got a whole lot better about it. And then when we stopped having those meetings, stopped talking about it, we got worse at it. So we keep the meetings going, and we have them on an ongoing basis. And we really encourage all employees to work at the top of their license, the top of their grades, and the top of their abilities. What we also learned is if you're not very efficient at the filling prescriptions fast, accurately, and cheap side, you'll never transition over into the kind of total cost of care side, because you struggle so much to get the prescriptions out the door correctly. So you really have to get that process down really solid before you start moving on. The other thing we learned is that complex patients require time away from the workflow. So you can't fill 500 prescriptions a day and expect to sit down and do an hour-long CPA intervention in between those prescriptions. You've got to dedicate individuals to have dedicated time and invest in those individuals to have the resources to sit down with these patients. And the real key is about that relationship building with the rest of the medical team. Our local relationships are what make this work. It does not and could not work all telephonically. It does not and could not work by having technology do it all. It's truly that relationship I have with that care manager where she knows she can call me in this situation, or I can call him or her in this situation, and we can loop back with the primary care doctors, and we're all sharing this message. Next slide. So, and Trista, if you want to jump in on this too, I don't know if we can both talk at the same time, but this is what's going on with CPESN and building these community pharmacy enhanced service networks across the nation. The orange states are states that have a launched network. The other colored states are states that are in development of their enhanced service network. So you can see your state and see where you stand on this map. And we would love to be able to loop you into a network in your state. Thank you. I'll turn it back over to Caitlin.
Thanks so much, Joe and Trista. We really appreciate your terrific presentations. And just to note, we're now going to move into the question and answer period. So a friendly reminder to submit a question, please click the question mark icon that's located in the toolbar at the top of your screen. I will just note that we have received quite a few questions, which is excellent. We are going to do our best to get to all of them. So I will start with the first one for Trista or Joe. How do you inform patients about the enhanced services, and what are the typical reactions from patients that receive care by CPESN?
This is Trista. Maybe I can answer that question from the care management perspective and Joe from the pharmacy perspective. So what we commonly hear from our care managers at CCNC is usually they provide education about the enhanced services once they realize the patient has some need that would benefit from an enhanced service. Again, limited transportation, maybe a really complex medication regimen that they're having trouble managing, no home supports, whatever it might be. And so usually they briefly describe to the patient what that service might look like what the delivery service would look like, or that adherence packaging, that you would have all your morning medications in a pouch or a card to punch out and take. So they normally describe those. The way we set up our network originally, we did these kind of group learnings or group meetings with the care managers and the pharmacies. So these folks know each other. In some cases, the care managers came into the pharmacies and learned what some of the services were all about. Or the local network, as kind of a convener, would have the care managers and the pharmacies come together and meet each other and do a little show and tell of the different services and products and describe what they do. So the care managers really do have taste, touch, and feel on this. And, the patient reactions are different. Some patients quite honestly say, I hear what you're saying, but I'm kind of happy with my pharmacy right now. I hate to change. And some of them jump on the opportunity and want to transition right then. The most interesting thing I've heard is care managers will say, it's rare if a patient just says no thanks and they stay no thanks. Often a month or two later, they'll come back to the care manager and they'll say, remember that pharmacy you told me about that does those blister card things to help me take my meds right? Yeah, actually, I think I'm ready to learn more about that now. So that's kind of the common experience on the CCNC side. Joe, what would you offer from the standpoint of patients in the pharmacy?
Yeah, I think that's very true. I mean, we are very open to inviting discharge planners, physicians, care managers into the pharmacy to see what we do and explain to them and just how this is different than your kind of filling prescription fast, accurate, and cheap model. The mindset that we're really trying to break is if your knee's hurting and you go to your family doc and he says, hey, Joe, you torn your meniscus, I'm going to send you over here to Dr. Bob, the orthopedic surgeon. We'll set you right up with that appointment. You'll go in and fix your meniscus on an outpatient. He'll keep you for 2 weeks and then hand you back off to me. You don't think anything about that. But if you go to your doctor and he says, you have diabetes, I'm going to start you on these 4 new medicines, he says, what pharmacy do you want me to call us into? You know, we want the conversation to be, I'm going to start you on these 4 new medicines. We have these pharmacies that we work with very closely, and this is an important disease that you stay on top of, and that these pharmacies know how to communicate with us. You know, we suggest that you go to one of these pharmacies to get your best care. So we really try to build it around that referral model. And the bottom line is, once they do start referring, they see the difference in care that the patients get, and then it helps out the physician or the care manager on their side give better care too, to have another partner to work with.
Great, thanks so much. Our next question is related to data and analytics. How do you determine which predictive criteria to use to determine which patients have the highest risk?
Yeah, this is Trista. I'll take that one since CCNC does the majority of the analytics for the network. Essentially, what we have done is we have a model that essentially looks in part at a patient's fill history and some of the maybe high-risk medications they're on, or their patterns of how they fill their medications. And really from that, we can determine how high risk a patient is and how much they need medication management. That might also put them at risk of a hospitalization. And those risk scores are calculated for all the patients in the pharmacy's care that meet the attribution criteria that Joe talked about. So all the patients that meet those criteria have, again, the risk scores calculated every month, and so the pharmacy from month to month can see this month Mrs. Jones is a 77, okay, now she's a 75, 75 again in the third month, whatever it is. So they kind of have a sense of where that patient is in risk against the rest of their panel. And that's really one innovation of the model. The vast majority of the pharmacies participating said they could guess, you know, based on their own clinical judgment, but they had no data prior to participating in a project like this that really helped them understand differences in patient risk scores. So that is definitely key to the model. We also really wanted to allow the pharmacies and the care teams around them to use clinical judgment, so we didn't create any hard and fast criteria around, you know, a patient must be this score or higher to receive services or to have a referral. Instead, you know, we wanted to leave it open. If Joe had a patient walk in his pharmacy that maybe had a risk score a little bit lower than what we would consider high risk, but they just came out of the ED with 3 different prescriptions that dramatically changed their medication regimen, we wanted Joe and his pharmacy to have the latitude to work with that patient in an intensive way and not wait till we see their risk score change, you know, because data lags obviously a month or 2 later. And likewise for care managers and providers, we wanted them to be able to act on referrals and essentially get a patient into a pharmacy's care for enhanced services as soon as they felt they needed it. So that's essentially how we've used the data and analytics. That is a little bit different than the scores we use to prioritize for care management. So it's a little bit different, but we think it really targets the benefit that a community pharmacy can provide to a high-risk patient.
Excellent, thanks so much. Our next question is related to the composition of the participating pharmacies. So can you speak a little bit about the breakdown of the participating pharmacies in terms of chains versus independent, and also your recruiting process?
Sure, how about I talk about North Carolina, and then Joe, you're probably in the best position to talk about what we're seeing in other states. Generally speaking, when we first started the North Carolina network, we were predominantly at that time in 2014 independent pharmacies, but it quickly grew within 6 months to a year, where we also included federally qualified health centers, so essentially the safety net providers that have pharmacies right there in the clinic. Those pharmacies are also part of our CPESN network. We also have a handful of health system outpatient pharmacies, not the ones that fill discharge prescriptions, but the ones that are actually off the hospital campus, like in a clinic building, for instance, where their medical clinics are. And then we do have Kroger participating in North Carolina, and we find grocers in general are a lot of what they do is align nicely with this model. And then another group of pharmacies called Genoa, which again has a footprint beyond North Carolina. And so it's not the model, like Joe said earlier, it's not meant for every pharmacy. It really does require the ability to customize, step out of workflow and customize the interventions to a specific patient's needs. We all know care team integration, coordination takes a lot of time and effort, and so we recognize this model is not for all pharmacies, and that's okay, because it's really 10 to 20% of the population, depending on what, what payer population or what group you're talking about, that really would benefit from this model. It's not every single patient that needs this. So we feel like that's okay, that not every pharmacy wants to participate, and it's more about wanting to provide care beyond just dispensing prescriptions. Joe, what would you add about pharmacy mix that we're seeing in other states?
Yeah, and I think that's pretty standard across the country. The networks are made up by the pharmacies that are in the network. So each network, each CPESN in each state can be made up, can look a little bit different, but they're all made up by the member pharmacies that are part of it. So some states have a lot of chain activity. Some states are primarily independent. Some have outpatient and the federally funded clinic pharmacies in it. And some of them are started and kind of put together by the State Pharmacy Association. Sometimes public health is involved in it, and they start up the network, so you get some public health there. So it is a mix across the nation. What North Carolina looks like is not exactly what Wyoming looks like.
Great, thanks so much. We have a question related to reimbursement. So as the participating community pharmacies, are you only being reimbursed for providing the drugs, or do you get a payment for the other clinical aspects that were described?
Trista can speak to our payment models, but part of the grant is to test out the payment model. So, Trista, do you want to kind of go into the different models that we've gone through and where we're landing?
Sure. Well, we've tested a variety of different models. I think one of our biggest challenges when we started this project is that community pharmacy largely, and not just community, but the pharmacists in general, regardless of care setting, are still looking for opportunities to be funded for their cognitive work or their clinical work beyond the dispensing activities. And so one challenge was really to transition immediately to a value-based, per member per month payment model would have been a huge learning curve for everybody. Everyone was still in the mindset where they really understood a fee-for-service model. So we started out there where there were per member per month payments for following up with patients once you did those intensive activities, and also PMPM for providing those enhanced services we described before, but then a fee-for-service payment around the intensive encounter. And then we've evolved over time to what we feel is the most sustainable model beyond the grant. It essentially is a per member per month payment that is both risk-based, so in other words, there's more payment for a higher risk patient, and so it's risk-based and it's pharmacy performance-based. So there's essentially kind of a grid where if you're a high-performing pharmacy and you're working with the highest risk patients, then you would receive the highest PMPM payment, and it goes down from there. That's been modeled on the payment amounts that Medicare uses for the chronic care management program. And so that's, pretty consistent with some other things that are out there, and certainly also consistent with how they really tier those payments based on patient complexity as well.
And what we've also found is, with some of our data, is that the patients that are referred are more expensive patients than a non-referred patient would be. So although we're not relying solely on the dispensing model to do all these extra services and extra care, it does drive a different type of patient to our pharmacy than our traditional patient. And the patient tends to be a more profitable patient even before you add in the PMPM payment that we get.
Great, thank you. We have a question. Are there any collaborative efforts for patients who access the VA for medicine?
That's a good question. I don't know about, any that are within the VA. Joe, do you?
I do not either. I know the VA has a fee-based service for patients who see physicians outside of the VA system that have VA benefits, but I do not know of a kind of a closed-loop VA system that has anything like this.
Thank you.
Yeah. Sorry, we're not familiar. They could have something like it, and we're just not aware. Sorry.
No problem. Thank you for answering. So just to shift gears a little bit, we have a question about communicating with non-English speaking patients. So are there particular strategies that the networks use to effectively communicate?
Yeah, great question, and we hear this a lot. More in some states than others, but it comes up in, I think, every state that we have activity of some type of CPESN network development, and that generally is always discussed as one of the service sets. So if you're a provider, you would be able to look at the pharmacies, and so we would end up with a core set of service sets. So maybe the things that Trista shared with you, ability to deliver, the ability to do a med rec, ability to do synchronization or deep dive clinical med sync, all of those are mandatory. So everybody in the network has to do these core service sets. Then there would be service sets on top of that would be considered optional service sets, and bilingual or multilingual maybe an optional service set. In some states, that may be a mandatory service set on it. So that does seem to be a high-need service set, and it has been discussed in every state. So you may go to Texas and find that is a optional service set in Texas, but 80% of the CPESN pharmacies have the ability to do that. And generally there would be some type of collaboration card or technology that would show you which pharmacies could and which pharmacies had the ability to do that and what the service sets of those pharmacies are.
Great, thank you. Our next question is definitely up your alley for pharmacists. What resources were used to generate scripts used for various disease states that are used by adherence techs?
Well, I can try to take that one. So the pharmacy community in general is a pretty tight-knit community, and people are usually willing to share pretty freely with one another. So we actually had a fellow pharmacist that was running a different Centers for Medicare and Medicaid Innovation Award out in California, and he built the algorithms that we're using in his program, which was run out of a federally qualified health center. Really just based on, what we know to be the current standards and current evidence around disease state management, and then kind of put into a protocol that a non-licensed person could answer questions about and then refer to the licensed person for certain responses that the patient gives. So I need to give a nod for the work that we did. A lot of it came from Steve Chen's group at the University of Southern California. But we certainly added on to it with behavioral health resources. But by and large, we really just go to the practice guidelines for those particular disease states is where everything comes from.
Thank you. We have a question related to packaging. So when using adherence packaging, how do you handle changes in the medication regime?
Yeah, that is always a challenge, and that gets a lot of conversation. So that is different from pharmacy to pharmacy. I don't know of any service set that dictates exactly how medication changes are handled. So it may be a service set that they have to do adherence packaging, but it doesn't. It gets brought up a lot, but I don't know that there's a service set directly around it. So some pharmacies will take the stance that, we'll do it on a case-by-case basis. If it has to be, go back out, get the packaging, come back and repackage, we'll do that. If you could finish out that month, by doing that in a vial, you could do that. We've had, personally at Moose Pharmacies, we have really good success with communicating back with the care team and say, hey, does this change really have to happen have to happen in this cycle. What we see a lot of times is, oh, well, their cholesterol is not at goal, we're going to increase the dose. And when we talk to the physician, we're like, yeah, I mean, that can wait 17 more days until the new cycle's out until you change it. So just wait on the cycle. So I think pretty universally it is handled on a case-by-case basis.
Thank you. We have a two-part outcomes question. So the first part is, what is the criteria for determining high-performing pharmacies? And the second is for outcomes measurement. How do you attribute responsibility for the outcomes to pharmacists versus case managers or others?
Yeah, good question. Probably the CNC side. So for the types of outcomes, could you repeat the first half of that question? Sorry.
Sure. So the first part is what is the criteria for high-performing pharmacy?
Yep, the criteria. So in general, we basically look at the statewide means for all pharmacies on total cost of care, inpatient hospitalizations and ED visits, and then a couple of measures of medication adherence. And basically what we do is we say any pharmacy that's performing at least one standard deviation above the mean or better is in the ultra high performing category. And then obviously any pharmacy that's doing better than the mean is slightly better than average. And so that's what we use, but for very few of those emerging networks that Joe showed do we have those kind of robust data sets. So really what we're striving for is a high quality network, so one that really delivers in a robust way the type of services Joe described, that, they're not just synchronizing the medications, they're also checking in on a patient's disease states and actually ability to meet their, therapeutic goals, and that they are working with their care managers and providers and things like that. We're also utilizing patient experience data, not on a broad scale just yet, but we're very close to being able to use patient experience surveys on a broad scale. Right now we're using them at the network level. We'd like to get to the point where we're using them at the pharmacy level in order to assess really just, how the pharmacy is performing and what the patient's perspective is on those services that are received. And then to your second question about how you attribute those results, what we do is for primary care, it's pretty easy in North Carolina because patients, when they sign up for their Medicaid enrollment, they actually, if they're within the CCNC system, they choose a primary care provider. So there's no attribution needed on the medical side. For pharmacies, we use specific criteria. We basically require that a patient has more than one chronic medication, and really what we're trying to get at there is, like Joe said earlier, the focus here is on chronically ill patients. So they have to have at least one chronic medication, and if they fill more than 80% of their prescriptions at that pharmacy in the most recent 3-month period, then that tells us that that pharmacy is their quote-unquote pharmacy home. Just like your patient would have a medical home, well, that pharmacy is their pharmacy home if they meet those criteria. So essentially all patients that meet those criteria in a given quarter, we look at the, same information on total cost of care, ED visits, and what have you, and we just run it based on the attribution criteria for the pharmacy. And so we can't really say directly, here's exactly what the physician contributed versus the care manager versus the pharmacist. I don't know of any team-based model that's able to tease that out cleanly. It's just very difficult to do. But what you can do is take the same data set, and based on your either attribution logic or your assignment, or patient selection of their physician, then you're able to slice it and dice the same data set just different ways so that each different provider can have their own view into that performance. But certainly it's still a team-based care model, and none of those individuals could really succeed with those types of measures in isolation, I don't think.
Thank you. So we have a question about collaborative agreements. So do you have any collaborative agreements with primary care providers to modify the medications for patients? Example, disease management programs.
Joe can speak maybe to what he's seeing in other states. In North Carolina, we don't have very many pharmacies that have these types of relationships. There are a few, But I think it's important to understand that that is by no means a prerequisite to this type of model working. It's actually quite the contrary. In our view, this model might precede something like that being a possibility, but by no means is it required or necessary for this model to be successful. I think through this model, pharmacies build closer relationships and collaborations with their physicians, which might or might not ultimately end up in a collaborative practice type situation. Certainly it allows them to work together in a little more seamless way without all the back and forth or as much back and forth communication on things that are indicated in that protocol. But again, definitely not a requirement. Joe, what would you say you're seeing in other states?
Yeah, I think it's the same way in other states. Even those states who have, pretty robust laws around collaborative practice, it's not necessary for this to work. I mean, we all we're doing medication optimization, and a lot of times it is helpful if you have the ability to change it, but the relationships you build may work you into that if you don't have it. So we've got physicians, when we first started this, that we requested lab data on, and it was always, well, you've got to get the patient to sign, a release and all this stuff, and it was a real problematic. I mean, I'll give you one example. We went to one clinic that we have a lot of patients with, and we said, hey, can we get EMR access to see lab data? And they're like, oh, no way, we could never do that. So we just started requesting it, and we requested it, and they keep sending it to us, and it got where at first there was a lot of resistance, and then it got where it was, every time we requested, they'd just send it right on over. They knew exactly what we needed, and they would send it over. And then one day we had a meeting with them, and they said, why don't you just get in our EMR and get this yourself and quit bugging us about it? And we're like, well, that's what we tried to get a long time ago. Thanks for coming around to that. So I think the relationships here. We also have pharmacies who have worked with primary care docs and around patients, and the more they work with them, the physicians go, they're working into roles where they're doing chronic care management and adult wellness visits and, with the physician and co-locating for some of their activities in the primary care clinics.
Thanks so much. So we have a question related to training. Is there ongoing training to the team when there are updates to medication guidelines or other protocols?
That's a good question. Oh, go ahead, Joe.
Well, I think we're getting ready to say the same. We really don't put out guidelines on what you should do on a day-to-day basis, but we are big on sharing best practices. So if we find a pharmacy who is really doing something great around diabetes, we'll share what is going on. So much of what we do is care coordination. So a lot of times it's not, does this patient who is on this beta blocker, does it have ISA activity or not have ISA activity, and should it? It's, does the patient even have access to their medications, and do they need delivery? So a lot of the best practice sharing is around the coordination of care as much as the actual guideline changes and those types of things.
Yeah, and the only other thing I'd add to that is, Joe and I are both pharmacists, so we can see what it is like for other healthcare professionals. But for us, I mean, there's educational opportunities all over the place as it relates to disease state, updates on guidelines, that sort of thing, new drugs on the market. But there's not education anywhere about how do I turn my, like Joe said, the delivery driver that just had a good driving record, 5 years ago, into the type of driver Joe's talking about, really engages with the patient a lot and needs to have that trust and be that conduit for communication with, via the delivery driver for the pharmacist, for instance. That's a very different skill set. And so those are types of best practice sharing that these pharmacists need as compared to, what are the latest medical guidelines for diabetes or what have you.
Excellent. Thank you so much. We have one final question. So the last question, we're combining it a little bit. Everyone is really hungry for more information. So Can you tell us where others outside of North Carolina can find information about CPESN, as well as are there any details of some of the great outcomes and findings that you spoke about today so that others may join the movement?
My favorite question.
Yeah, absolutely. Absolutely. So, Joe, go ahead.
So you can go to info@cpesn.com, and if you have specific questions that you want to ask us via email, that's info@cpesn.com, short for Community Pharmacy Enhanced Services Network. If you can go to cpesn.com, the website, which is currently being built out, and then, Trista, you can speak to the grant results.
Yep. So our CMMI award in North Carolina is toward the end of year 3, but as many of you can appreciate, it takes some period of time for the data to accumulate. We definitely have some initial very encouraging results about how the community pharmacy network really augments and is additive to the CCNC model that existed before, but we won't be able to release those formal results for some number of months. So we're able to share with you that it's kind of very encouraging and to stay tuned, but no specific results to release at the moment.
And if you want to email me directly with a question, that's jmoose, M-O-O-S-E, @cpesn.com.
Terrific. Thank you so much. Fantastic presentations, great dialogue, and we look forward to seeing those outcomes. So just a reminder, this is our 3rd webinar as part of our 3-part series, and we have some publications listed here that you can go and visit on the CHCS website, and additional resources on community health workers, community paramedicine. And in closing, we just want to say thank you so much for joining us today, and we look forward to seeing all of you in the future. Have a great afternoon.